we just discovered that to have an electrical appliance work, you've got to turn the power switch on first. We didn't know that. Wonderful world of technology. Now today, we want to talk to you about the coverings of the brain, the things that, in a sense, protect the brain and contain the cerebrospinal fluid. Then we want to talk about the channels within the brain, the ventricles, through which this fluid moves. And finally, we want to talk briefly about the vascular system that supplies it. And then we'll also handle the baseball scores and so forth. You know, it's, we don't have much to do today, but I do want to get a little bit of all of this to you so that we're familiar. And I think what we'll do is start with this picture. It's a rather dramatic hemisection right through the head of the cadaver, of course. The reason I wanted you to see it is because it shows very neatly the relationship between the brain itself, which we see, we're looking at the medial aspect of the brain. We see here, of course, the corpus callosum, always visible in such a section. And we can see here rather better than we saw in the sheet a few days ago. We can sort of look into the lateral ventricles. We'll talk about those in a minute. But what I want you to see primarily is the cerebral hemisphere, and then this very thick outer membrane that's applied on the one hand to the inner table of the brain, of the skull, beg your pardon. Here's the skull here, of course. And here is this heavy membrane. Inside of it, we'll find there are actually two more membranes and some space. And in this space is part of the circulation area for the cerebrospinal fluid. And rather neatly, we can look at the brain, we can watch the diencephalon here, you can see the midbrain, you see pons in the medulla, and you see cerebellum. This is all going to become, of course, increasingly familiar to you. Let's go on now and look a little more at detail. Now what we've done here, and by the way, the coloring book I think is quite good on this material. What you have here is a small section through cranial bulk, that is to say, that's the skull. Then the brown is the outermost of the three layers that protect the brain. We call these layers the meninges. And this outermost layer is known as the dura, or dura mater. What does dura mean? Dura means hard. Mater, most of you know, means mother. So this is, in a sense, the hard mother. This is the tough membrane that surrounds and protects the brain. Although it looks like it's a single layer, at certain places it divides into an inner layer and an outer layer. When it does, we call this inner layer the meningeal layer, and the outer layer the endosteal layer. I think these terms are on your handout sheet. And when they separate that way, what they leave in between is a little space that's lined by lining cells. We call them endothelium, if you know the word. And through these spaces, venous blood runs. So one of the roles then of the dura mater is just sheer protection. And by the way, it tends to get heavier and thicker and even somewhat calcified as one goes on in years. And then the second role is through various little divisions to make space for these little venous channels. We call them, by the way, sinuses or vascular sinuses. Different, of course, from the sinuses that you have in front where you have pain when you get cold. So the dura mater is the outermost layer. Then the next layer that's applied to the inner surface of the dura, and we see it here with a little space, we call this the arachnoid. Now, arachnoid means spider-like. And the reason this intermediate layer is called spider-like or arachnoid is because of these spider web-like connections that connect it to the innermost layer. So this is the arachnoid layer with these spider-like projections which attach the arachnoid to the innermost and thinnest of the layers. This is called the pia, or more completely, the pia mater, which means the soft mother. So you see we have the dura mater, we have the arachnoid, and we have the pia mater. Now, the space between the dura mater and the arachnoid is more, you might say, a potential space than anything else. It does open up when a vessel like this is traumatized and we get bleeding. And when we get bleeding in there, in this so-called subdural space, when we get bleeding there, we get a subdural hematoma. Has anyone here either had a subdural hematoma or have a friend who's had one? Anybody? A few of you have. Ordinarily, when you get a hard hit on the head, matter of fact, even getting a good clunking by a volleyball when you head the ball, sometimes that may be enough to cause some injury of a little vessel here, leakage of blood into this place, and with the continuous leakage, we'll see in a moment, I have a picture to show you, with that continuous leakage, this space balloons out and begins to put pressure on the underlying brain. Let me show you what it looks here. Look at this tremendous subdural that's developed here following a severe injury. And this, of course, becomes a surgical emergency. You have to put a hole in and pull out all of that blood so that the brain can reestablish its shape and, of course, its function. Let's go back to this one. In this space between the main part of the arachnoid with its trabeculae or spider-like extensions to the pia, this space is known as the subarachnoid space that many of you have heard of. And in here, we have many of our major blood vessels running. And equally important, this is where cerebrospinal fluid sloshes around and runs. If you have a blowout of an arterial vessel, and we can get blowouts with little outpouchings. How many here have heard the term aneurysm? Most of you know it's a little weak spot in a vessel, usually an artery, which blows out and it bursts. You get bleeding in here. Then you get a subarachnoid hemorrhage. See, this was a subdural up here. This is the subarachnoid, usually due to arterial bleeding. That again becomes a surgical emergency. Now the pia, as I say, is very, very thin. It's really, when we look at the sheep brain or the human brain, all we can really see of the pia is sort of its glistening appearance, closely applied, in this case, to the cortex of the hemisphere, but there's pia on all CNS. The pia follows each gyrus and sulcus, and often, usually, follows the larger vessels that perforate through the cortex. See that? So the pia is the most intimate, protective layer for the central nervous system. So these then are the three layers of meninges, and as I say, they are constantly doing their job. Now the reason that I show you this is a slightly different version of something that's also in a coloring book. Here we're right at the midline. In other words, right here at the vertex of the head and at midline. And at midline, notice that here's dura out here. We have a major splitting away of the meningeal layer of the dura from the closely bony connected or endosteal layer. And what we have here then is a major vascular channel. This is one of the large venous blood carrying sinuses. We call it a superior sagittal sinus. And there are probably half a dozen more or so of these that have been identified. And then look what happens to the remainder of the meningeal dura. It continues on down between the two hemispheres. Here we see the gyri and sulci of one hemisphere. Here the gyri and sulci of another. This is a greatly expanded, obviously for our purposes, a greatly expanded subarachnoid space. And this glial leaf that continues on down through becomes a kind of protective partition between the two hemispheres. In part, it keeps the hemispheres from banging together as we move our heads around. And that has a name, everything has a name, and it's called the falx cerebri. Well, if I can find a little button. No? Where is it? Here it is. The falx cerebri. We're going to find there are a couple of these fused sheets of meningeal dura that have a protective effect. One of them is this falx cerebri. Another one, instead of sitting vertically, sits more or less horizontally in back between the hemispheres and the underlying cerebellum. And that has a lovely name. We also have that down on your sheet. Don't put this down now. We call that the tent over the cerebellum. It's sort of nice, but it's low class. It's only English. So we put it into Latin and we call it the tentorium cerebelli. So in the falx cerebri and the tentorium cerebelli, we have two examples of this specialized meningeal layer of dura coming down to help protect parts of the brain from each other. And I wanted you to remember that. Now, let's look again at this subarachnoid space. Here are those spider web-like trabeculae that connect the arachnoid to the underlying thea. And look at this little nipple-like shaped structure. All along the superior sagittal sinus in particular, these little nipple-like extrusions project from the subarachnoid space into the superior sagittal sinus. We're going to find in a couple of minutes that cerebrospinal fluid is manufactured largely in little puffs of vascular tissue called choroid plexus. And the choroid plexus is found in virtually all of the ventricles. Cerebrospinal fluid is constantly made, but it has to be constantly discharged so that we don't pick up too much intracranial pressure. The discharge of the cerebrospinal fluid occurs through these little arachnoidal villi is the plural, that project the fluid back into the venous blood system. And there it just mixes with the plasma and becomes lost and adds to the circulation again. We'll also find that somewhere between 400 and 700 cc's of cerebrospinal fluid are manufactured every day. So manufactured and resorbed. And here you see the primary, not the only, but the primary mode by which cerebrospinal fluid is piped back into the circulating blood. This we've already seen, the rather awful effects of a large subdural hematoma. Now, this sketch, again from the coloring book, allows us to look at the overall circulation of cerebrospinal fluid. It's been estimated that at any one point in time, right now, as I look at all of you, see a handsome group, looking at heads, I'm looking right through to your brain, and I'm looking right through to your cerebrospinal fluid. Did you know that? I can see it. You have between 140 and 150 cc's of cerebrospinal fluid at any one point in time. So that's the fluid that you actually have circulating at this particular moment. The roles of the cerebrospinal fluid we don't fully understand. For one thing, it undoubtedly acts as a sort of a hydraulic shock absorber, so that when the brain is suddenly displaced with a sudden head movement, there's enough squishiness to take up some of that rapid motion. But it also apparently functions as a kind of slow thoroughfare for bringing various molecules from one point to another. And we'll speculate about that a little later as the course goes on. Now, how is it formed? Well, I told you it's formed in a spongy vascular tissue called choroid plexus. We find hunks of choroid plexus in the lateral ventricles. We're looking in on the lateral ventricle, and we're seeing some here. Some of it is formed in the third ventricle. We see a little choroid plexus here. There's none in the aqueduct of Sylvius. It's much too narrow. But in the fourth ventricle, we see some choroid plexus again. So between the plexi in these three areas, and there's also a little leakage of cerebrospinal fluid from other points, this makes up our total amount on a moment-to-moment basis of this fluid. The fluid is rather like blood plasma, although it has different concentrations of protein, different concentrations of sodium and potassium and so forth. So this is an active secretory process in the choroid plexus. And the flow, the direction of flow, is from the lateral ventricles through a connecting little area here, the so-called, we'll talk about this again in a moment, through the interventricular foramen of Monroe, into this large but very flat, very narrow third ventricle, then down through the aqueduct of Sylvius, the cerebral aqueduct of Sylvius, into the fourth ventricle here, and then from the fourth ventricle, the fluid can get out through either a midline little hole, the foramina of Luschka, that's on your sheet, or two little lateral holes, one located here and one on the other side, the foramina of Meninges. And once the fluid has come out there, it then runs through this subarachnoid space. Let's see, where is it? It's right here. Through the subarachnoid space. And gradually makes its way back to the vertex of the hemispheres, where it's picked up by those little nipple-like structures I told you about, the arachnoidal villi, and injected back into the venous system. Small amounts of the fluid, of course, instead of going back up this way, continue through subarachnoid spaces around the spinal cord, and so you have a complete washing of the system all the time. And as I told you, if you want to do a lumbar puncture, you go in down here, usually between L2 and L3, somewhere here, where you're below the spinal cord and can sample out a little bit of that fluid. There's one other structure I want to mention to you. Look over here. Here's the cerebellum. Here's the brain stem. And the dura and arachnoid membrane are going this way. They're usually fairly closely applied to just the subarachnoid space between them and the brain. But here, where you have this very acute turn, notice this much larger space that's left. This is simply an enlargement of the subarachnoid space. There are several such areas, and they're called cisterns. You've all heard of the word cistern, fluid carrier. These are called cisterns. This one in particular is the large cistern, or in more elegant Latin form, the cisterna magna. Why do I mention that? If some of you become pediatricians, and you want to get cerebrospinal fluid from a very young patient, it turns out to be very difficult to get cerebrospinal fluid down here where you would from an adult. So what you do is you pray first, and then you go in here at the junction of skull and neck, and you put a long needle right through here into the cisterna magna, and you get out a sample of your cerebrospinal fluid. Quite clearly, you don't want to go too far, because this very important area of medulla and pons is just beneath. So that's why you pray a lot when you do it. But it is the primary way of getting cerebrospinal fluid from an infant. So the cisterns, and in particular, the cisterna magna, does have real clinical import. What about ventricles now? We've talked about ventricles. They are, of course, the spaces within the CNS. Let me just make a very brief sketch for a moment, just to show you how the one leads to the other. We'll do it this way and put on these forward lights too. If you remember, yesterday we were talking about the development of the neural tube, and the neural tube closed, and we had first just a tube, hollow. Remember, we had an inside sort of neural canal, if you will. Then this began to develop the vesicles, first the primaries. That also, of course, was a tube structure with walls. And then I began to tell you that this most anterior, or prosencephalon, developed mouse ears or rabbit ears, I forget which I said, and we had something like this. We still had the system of the internal canal and so forth. Now, as this increases, it's much larger in size, and the walls begin to thicken. Some of this space in here remains, and it is this, you see, which becomes the ventricular system, a continuously present, fluid-carrying set of channels inside the substance of the brain. I just wanted you to be sure of where these ventricles come from instead of just talking about them as something that materialized who knows where. So, we're looking both at a lateral and an anterior view here. And let's take this lateral view first. Here's the ventricular system, here's the surrounding brain. The anterior horn of the ventricle, see, projects quite a distance into the frontal lobe. The posterior horn projects a fair distance into the occipital lobe. The inferior horn projects down pretty much into the temporal lobe. And this is called the body here, the central part, not too difficult to remember. But this pattern now characterizes the ventricle system in each of the two hemispheres. Somebody asked, well, is there a first ventricle and a second ventricle? We don't like to show favoritism, so we simply call these the lateral ventricles and know that they include the first and second. Whether the first is left or right, nobody knows. So you have the lateral ventricles, and they are connecting through this very small, and by the way, we should see it next Tuesday, most of our human brains, connecting through this very small interventricular foramen. A foramen is a hole. Interventricular speaks for itself. A man's name is often attached to this, Monroe, the interventricular foramen of Monroe, which carries fluid into the third ventricle. And the third ventricle is this very thin, narrow, it's high from dorsal to ventral, but very thin, a cleft between the two diencephalate. Here it is. And it continues, it has, by the way, it has its own choroid plexus, just as this area does too. It continues back, we don't see it here, it's sort of behind, through the beg your pardon, through the, what do we call that? Blocked out for the moment. What's the narrow channel called? Beg your pardon? Aqueduct of Sylvius, right. Just had a complete block. Through the aqueduct of Sylvius into the fourth ventricle. And remember, from the fourth ventricle, via a midline foramen of Lejeune and two lateral foramina of Luschka, most of the fluid then flows out, enters the subarachnoid space, and will eventually be resorbed. Looking head on at the system, rather neatly, notice how the anterior or frontal pole, they're quite close to midline. And then as we go back through the body to the posterior horn and inferior horn, notice that they tend to belly out laterally. Now the appearance of this ventricular system is highly pathognomonic for pathology. What does pathognomonic mean? It means it tells a specific story. As these ventricles are displaced from their parallel symmetrical position, we know that there may be a developing tumor, a space-occupying lesion, or a developing hemorrhage, so we obviously look for that. Another thing we look for with concern is progressive enlargement of the ventricular system. On the one hand, it may mean that pressure is building up somewhere here due to a blockade. See, the fluid keeps being produced, but if the pressure, a little site that holds up the fluid develops, the pressure increases and these things begin to belly out, and that can become a surgical emergency. A third cause of enlargement of the ventricular system is progressive atrophy of the cortical tissue, particularly the white matter surrounding it. In our studies, everybody studies of Alzheimer's disease, of progressive, degenerative, dementing disease. We always keep a very close eye on the size of the ventricles. Very often, you can see ventricular enlargement well before the patient begins to show any signs of degeneration. Interestingly enough, an enlarged ventricular system can also be seen in most schizophrenic patients. And one of the ways, for instance, that we can sometimes identify which of two sets of twins, very often identical twins, which of two of a set of identical twins may become schizophrenic is the one who already has a somewhat enlarged ventricular system. So these become very important in diagnoses of brain disease, and I just wanted you to have that in your mind because, as I say, it's of great concern to the clinician. Now let's talk a little bit about the vascular system. This is a very interesting picture. How is it made? right after death, a large amount of a polymerizing plastic was slowly and continuously injected into the vessels that supply the brain. After as much was introduced as could comfortably go, the substance was given time to polymerize and get hard. And then, using either an alkali or an acid, I forget which, all the brain tissue itself was dissolved away. And what we had left was just the cast of the vascular system, reproduced, of course, by the plastic that had hardened and was still in there. And look at that. You have, you might say, a perfect cast of the brain. So dense and intense is the vascularization. Some people say there may be 10 or 12 miles of vascular channel in each one of our brains. Very, very possible. So it is it's something whose importance I don't think I can overemphasize. Brain tissue, especially cortex, has a very high metabolic level. As a matter of fact, your brain is a very expensive organ to maintain. The brain, the human brain, may weigh about 3% of the total body weight. And it takes over 20% of all the oxygen that you breathe. It's an interesting statistic. So it is indeed very expensive. It is a glucose burner. Burns exclusively glucose, so far as we know, in all the great central periods of your time. As you get older, it may also begin to burn glucose breakdown products, lactate, fluidate, and so forth. But as I say, it is a very difficult organ to maintain, and the vascular system, of course, which maintains it. Now, what is the vascular system that supplies it? There's a picture similar to this in the coloring book. There are lots of versions of this. What it simply shows, in a highly simplified fashion, are the two major blood supply systems to the brain. One supply comes up via the carotids. We'll talk about those in a minute. And the other supply comes up via the so-called vertebrals, which are here. Where do they come from? They both come from the aorta, the great blood carrier that leaves your left ventricle, as you all know, makes an arch here, projecting slightly to the right, and then coming down the left side and becoming the thoracic and abdominal aorta to take care of the rest of the body. The very first vessels, by the way, that are released just as the aorta is forming are cardiac vessels, coronary arteries. In other words, the heart is smart enough to know that if it's going to keep a healthy body with all that pumping it has to do, it first better take care of itself. That's what is known as enlightened self-interest. Once it's done that, it produces on this side a brachiocephalic artery, and on this side a subclavian artery. Now this brachiocephalic, which is only on the right, breaks up into the right subclavian, and its other branch is the right common carotid. The common carotid on the left, you see, has an origin all of its own right on the aorta. So there is some asymmetry here, but they then form the right and left common carotids, and you can easily feel these vessels here in the base of your neck on each side. You feel them pulsating. This is, say, one of the two great blood suppliers to the brain. Let's follow them up. At about the level of your thyroid cartilage, about the level of your Adam's apple, the common carotid splits. We say bifurcates. You have an external, which we're not going to pay attention to. It takes care of face and parts of the head and dura and so forth. We have an external. And we have an internal, and it is the internal carotid, which continues on up through the base of the skull, and then makes a few rather hair-raising turns, you see from here, and then is going to form, and we'll find out what it forms, is going to form two of the major arterial supply vessels for a brain. So, on the right side, the common carotid comes out of the brachiocephalic, splits into the right and left, into the external and internal carotids, and the internal then continues on through the skull into the brain. We'll follow that in a moment. The other major vessel is the vertebral. Now both vertebrals come off of the subclavian, here from the right subclavian and here from the left subclavian. We call them vertebral because they have a funny course. Instead of going up here rather superficially through the neck, they go back posteriorly, find the vertebral column, and then they actually go through the lateral bony process of each vertebra, and in this protected fashion go on up to the base of the skull. When they get to the base of the skull, instead of having little holes of their own, little entryways of their own, the way the internal carotid does, they go a little more medial and then pop into the skull through the foramen magnum, very close to the developing brain stem. And they also make a group of branches that we'll look at in a moment. Let's go to the next slide. And here now, we have just isolated the carotid system. Here we have the carotid again coming off, in this case, from the right side, from the brachiocephalic. Here's the common carotid. Here is where the internal and external carotids split off. In this area where they split, we have a group of sensors, the so-called carotid sinus, which is constantly sensing the blood pressure, blood going into your brain. And if the pressure begins to drop, the carotid sinus sets off reflexes to increase cardiac thrust, both increase the thrust and increase the frequency, because that precious brain has to continue to be oxygenated. But another interesting thing happens at this little area. Here it's shown over here. Because of the eddy currents that are set up by blood pounding through here, going in two directions, slowly blood platelets and other materials tend to congeal on the walls and begin to form a clot. And this clot can increase in size to the point where it actually embarrasses circulation going through to the brain. That can become, with time, a neurosurgical emergency. And there is a process, done many times each day. It's known as endarterectomy, which means you go inside and you remove some stuff, ectomy, remove some stuff from the artery. And you can actually remove this hardened oatmeal-like material that's cutting down your blood supply to the brain. Also, from this little glue-like substance, if it's a little more friable, fragments can break off and be carried up into the brain as traveling clots. We call them thrombi. And they, of course, can form a blockade in a smaller vessel, and then you have a stroke. So this is a very loaded area here, loaded with importance. Now watch what happens. We enter the skull, I told you, through the carotid foramen on each side. And here, your internal carotid breaks up into the two major vessels it's going to form. An anterior cerebral, which we can't follow here because it goes forward on the medial surface of the brain, an anterior cerebral, and a middle cerebral. Now the middle, fortunately, the middle we can follow very well. It goes laterally, just on the surface of the temporal lobe through that great lateral fissure sylvius. And then it goes out onto the surface and it supplies the entire lateral surface of the hemisphere. So it's funny. The middle cerebral supplies the lateral surfaces of the hemisphere. On its way through, notice that it's giving these very important branches to the areas of the internal capsule, which we'll learn about, the thalamus, and even some to the basal ganglia. Now these vessels are unfortunately the ones that are most likely to catch a clot, a thrombus, and shut off blood supply to a localized area in here. These vessels, they're known officially as lenticulostriate. Lenticulostriate, we'll have it down on the sheet. But they're known colloquially as the arteries of sudden death, because neural tissue is so compressed in there. There are so many important structures whose fibers are going through that even a relatively small lesion can produce disastrous results. So do remember that the branches of this middle cerebral, these lenticulostriates, are prone to real vascular difficulties and can produce, as I say, a stroke. The anterior, as I told you, goes forward between the hemispheres. Matter of fact, let me see. Here we see it in this lateral view, of course. Right here, let me see, is that correct? Yes. Here is the anterior cerebral. It's going around the corpus callosum, and then, I'm sorry, I'm not too happy with this drawing. This is all anterior cerebral, and between the branches of it, it succeeds in supplying, as I told you, the middle or medial aspect of the hemisphere. So the anterior supplies the medial aspect, the middle supplies the lateral aspect. Rather funny, but that's the way nature worked it out. Now this last picture, again from your coloring book, shows you the course of the two vertebral arteries that are coming up. I told you that after they go up through the bony lateral processes of each vertebra, when they get to the base of the skull, they go more medially so that they can pop into the skull through that big hole, the foramen magnum, through which the brainstem protrudes. And they follow up, applied very closely to, here's upper spinal cord, here's brainstem, here's medulla, here's pons, midbrain up here, and diencephalon here. These two vertebrals fuse at about the pontine level and become the basilar artery. Now the basilar gives off a number of important branches. A couple you see to the cerebellum, so-called posterior inferior cerebellar, and anterior inferior cerebellar, and also some spinals that go back on down. This is all in your coloring book. Branches to the brain stem, and then the last branch is the major terminal branch of this basilar artery. See it splitting? It becomes the posterior cerebral artery. And the posterior cerebral projects backward and it primarily vascularizes the occipital lobe and the most posterior part of the temporal lobe. And we can sort of see it doing that here on the surface. Up here, all we see is the stub end, the cut end of the internal carotids that have come in from below and are now dividing into an anterior cerebral, as we mentioned before, and a middle cerebral. See, we've cut away some temporal lobe to show that to you. And this is an enlargement of this area. This area we've enlarged. So we have the internal carotids coming up from below, this way and this way. And they produce two anterior cerebrals and two middle cerebrals, as we've mentioned to you. Here are the two vertebrals coming up. They produce a midline basilar, which after producing these branches terminates in a great posterior cerebral. So we have the posterior cerebral, the middle cerebral, and the anterior cerebral. Now, are these two systems connected? Remember I told you when I ask a rhetorical question, the answer is usually yes. And they are connected by a so-called posterior communicating artery here, and a little anterior communicating artery here. So between these, we have what looks functionally like a circle. It's known as the circle of Willis. Probably the circle of Willis does not carry significant amounts of blood in a normal state from one side to the other. We have some proofs of that. But in the case where you have a severe blockade on one side, then these vessels quickly open up and become meaningful vascular channels so that one side can help supply the other side. And that seems to be the main role of the circle of Willis. So it's made up, remember, of the two posterior cerebrals here, posterior communicating arteries that connect it to the internal cerebral circulation, and then as we follow the anterior cerebrals anteriorly, an anterior communicating, a single one crosses midline, and so we are left with a circle of Willis. Now, the last thing that I'm going to mention to you before we stop is that with all of this important small vessels, all projecting out often at right angles, vascularizing the overlying diencephalon and the internal capsule, what have you. In all those little side branches, it apparently leaves the potential for weak spots at these branches, weak spots. And these dotted lines indicate where many of these weak spots are. The result of a weak spot is an aneurysm. They pouch out, they develop. Those aneurysms, they get larger and they break. And as I've said, a ruptured cerebral aneurysm then becomes a surgical emergency of the first kind. It bleeds, it produces a subarachnoid hemorrhage, does all kinds of bad things. And the job then is to go in as quickly as you can. This is a difficult place to get to, as you can imagine. And at least get a clip over the base of that aneurysm, trying to stop the bleeding. There are other techniques now in which they use MRI or PET scan and actually try to guide a small coil of wire into this, or even guide, using outside magnets, guide little hunks of metal filings, iron filings into this thing, just to stop that bleeding, to save the patient. So this is, you see, a very important area of the brain, and clinically, obviously, a very significant one. Now, folks, two things. Remember that we'll have the review on the 6th floor, right above us, at 5 o'clock, and I'll have my office hours now. So, we'll see you.